Yeah, welcome to everyone. Thank you for coming along. My name is Daniel McDonald. I'm a sports physio, and this is Lauren. We're both accredited GLAD physiotherapists. Has anybody heard of the GLAD program at all before? No? It's been getting quite a bit of kind of airplay on commercial TV and those sort of things. So yeah, I think you'll probably hear about it a lot more in the next couple of months. We're actually the first clinic that is running the GLAD program. And the idea of this session basically is to teach you guys a lot about what osteoarthritis of the hip and knee is, and to really remove some of the myths and fears around it, and also explain some of the treatments available out there, the good ones and not so good ones. So just show of hands, who here has got osteoarthritis of the knee? Yep. Osteoarthritis of the hip? Both? Yeah? Yeah, cool. And I guess probably hands up, who does it impact your lifestyle at all? Yeah, yeah, 2 hands, yeah. All right, so as I said, GLAD was a program that started in Denmark, and then it then moved on to Canada, was the second country to implement it. So just with this talk, I have to kind of acknowledge that that's where it started, and Australia is now the third in line getting the GLAD program. So what is GLAD? So GLAD stands for Good Life with Arthritis Denmark. I haven't kind of made an acronym for Australia yet, but I guess it'd be GLA or something, but that doesn't sound as good, so I'll just keep on calling it GLAD. So basically, GLAD is 2 education sessions, the first of which is this one here. And what it's shown is that, like any condition, if you know more about your condition, you manage it a lot better yourself. Okay, knowledge is power. The more you know about it, the better you'll be able to manage your life. And so you get 2 education sessions, then you also get 2 one-on-one sessions with a physiotherapist. And what we do is we actually do a couple of objective tests so that we can see exactly where you are in terms of your function, and then we retest those things after you've done the program, and we actually monitor how much effect the sessions have had on your progress. And then you do 12 supervised or unsupervised exercise sessions, and those exercises are designed specifically for people with knee and hip OA. Okay, so they're basically gold class exercise sessions, and that runs over a minimum of 6 weeks. But some people take longer to do that. And then we retest, as I said, your outcome measures. And on the GLAD program as well, you also go onto an international database. And so they basically monitor everyone's outcomes. And what has been shown is that people that completed the program had, on average, a 32% reduction in their symptoms. So I think that's pretty amazing. There's not a lot of medications out there that can do that. Absolutely, yeah. And I'll explain why. So you get less pain, more movement, better quality of life. And there's a number of reasons why it does that. And that's what these education sessions are designed to do. And whether you come on the program or not, that doesn't matter. Even just having the knowledge of how should I move, how much can I move, what sort of exercise I should do, is really going to help you in your day-to-day life. As I said, there's a lot of... Yes, sir? The GLAD program's only to an easy yes. You can do it separately, but again, some of the principles in terms of how you should exercise are the same. So we teach you how much pain is acceptable when you exercise, how long pain should last afterwards, and that really should guide any form of exercise you do, whether you've got spinal OA would be the other big one, ankle OA. The principles are really much the same. Okay, because a lot of messages you have probably heard in the past is from TV shows, sometimes even doctors, is that pain equals damage. And it doesn't. Okay, so this is about trying to get you guys less scared of moving, but knowing how to do it safely and effectively, so when you move, you don't keep on getting sore and then stop moving and then go through this kind of repetitive cycle. Yeah. So GLAD is specifically for hip and knee OA, but some of the principles would be the same. Yeah. I was going to say, any questions, please, put your hand up as well. I really want to make this kind of as much an interactive session as possible. And hear any experiences or questions you guys have got, so please fire away. So to do a GLAD, so only a GLAD trained physio can take the program. Yeah. So if you see a physio, it has to be, so in this practice, myself and Lauren are GLAD trained physios. Yeah. So the program has to be run by one of us. Yeah. Yeah. So it's a whole course you've got to do to become accredited in GLAD. So yeah. In here or elsewhere around the... Not in this year. So we're the first clinic to start this program up. Yeah. Yeah. So I don't know about the Gold Coast, but definitely on Sweden. Yeah. Cool. So the objectives of today's talk is to get a better understanding of osteoarthritis, some of the risk factors associated with it, some of the symptoms of it, which I'm sure you'll all be familiar with, some of the treatments available out there, and tips to help yourself manage it. Okay. And also, this will result in less pain and a better quality of life. And it's very, very clear, which is what I'll explain to you, that the research is very, very clear at the moment. The best treatment for osteoarthritis is exercise and weight loss. Okay. That's really, really clear in the evidence now. Everything else, which I'll go on to explain, has only very limited or no evidence at all. Okay. But what we see is that people are getting referred for injections, for platelets, stem cells, all this stuff. But actually, there is no evidence that it works. So that's what the idea of today is, to try and sort of, again, clear up some of that kind of misunderstanding. Okay? So this first session I said is about that. Now, we also do another second session. The second session is basically on a bit more detail in terms of how to exercise properly. I will cover that a little bit today, and also how to self-manage osteoarthritis. Okay? As I said, the second session is free, but only people that are actually on part of the GLAD program can attend the second session. So anyone from the public can attend the first one, and we'll cover most things, but the second session is really specific to exercising in that GLAD program. Okay? So what is osteoarthritis? So osteoarthritis is a disease that affects the whole joint, and it's the most common reason for not being active as people age. Okay, basically the stats are showing that over sort of 40% of people over the age of 40 have osteoarthritis of the hip or knee, and as you get into 50s, 60s, 70s, that becomes even more prevalent. So it's more common than diabetes, and so it's a really extremely common health occurrence. It's a lifelong joint disease. You can start without any obvious reason. You don't have to have a trauma to the joint. The cartilage on the edge of the bone starts to degrade thin and sometimes disappears, and also the joint capsule ligaments and the muscles around that affected bone also get affected. Okay, so basically, essentially what it is that when you have a joint, on top of that joint you have a lining called articular cartilage, and over time that cartilage starts to degrade and then starts to wear away, and then eventually, the end of it is what a term I hate to hear is that bone on bone, where you have a complete loss of articular cartilage. But again, a very important take-home message from today is that the degree of wear and tear in your knee or hip does not correspond very well to the degree of pain or symptoms that you feel. Okay, we have people come in here that have very, very mild symptoms with really, really quite extreme x-rays, with no joint space at all. You get the flip side where you have people with very mild x-ray changes, but very, very extreme pain and symptoms. So that's why I'll explain that there really is no point getting x-rays for knee or hip OA. From a clinician's point of view, they tell us nothing at all, because there's no correlation between what you see on the x-ray to what you feel and how you move and lead your life. All it does is if you go get an x-ray and it tells you you've got bone-on-bone arthritis, you just tend to worry about it more and you move less, and so it's quite it's quite counterproductive. Okay, but again, nationwide, if you were to go see your doctor, say there's 100 people in this room, 20% of those people will on average be referred for an x-ray that you don't really need. Only 3% would be referred to an exercise program. So the message is not quite out there yet. Okay, as I said, exercise should be the first line of treatment for osteoarthritis. It was previously thought that osteoarthritis was a wear and tear disease, which has basically led to most people with osteoarthritis thinking that they shouldn't move. Okay, and again, that's the biggest take-home message from today. That's in fact wrong, and I'll explain why that is. So cartilage needs loading and it needs movement to lubricate. If you don't move your knee and don't move your hip, the cartilage loses its normal lubrication and you stiffen up and the arthritis gets worse.
So can cartilage regenerate once it's continued to join?
No.
There's no way for it to repair, like maybe a scratch.
Yeah.
With cartilage once it's degenerated.
Correct. Yeah. So it has very, very, very poor blood supply. So it can't sort of can't regenerate. Obviously there is things on the market like glucosamine and that claim to do it. Yeah. But it's again the evidence is not there that that actually happens. Okay. Again, just go back to that thinking that it doesn't really matter how much cartilage you've lost. It's not coming back, but also that doesn't correlate to how you should feel. Yeah. So even if you've got bone-on-bone arthritis, you should still be moving. It's dependent on a lot of factors, basically. Capabilities, yeah. So that's really the take-home message from today: is that cartilage needs movement and loading to regenerate. Okay, and by regenerate I mean not grow, but there's a cycle of when you move, and like muscles, when you move muscles heavy, go to the gym, it needs to repair, so that it needs movement to repair itself. Okay, does that make sense? Yeah. So as I said, I hate hearing that term. It's a wear and tear disease. Okay, it's not. It's a joint dysfunction that leads to thinning of the cartilage. Because wear and tear again to me says. It's nasty words. It conjure up images of you're broken, and we want you guys to actually be encouraged to move. Okay. Right. So again, just going back to those facts. So it's more common than high blood pressure and diabetes. It's the most common lifestyle disease in people over 65 years. Knee and hip pain are common. 30% of people age 50 above report hip and knee pain, but only 5% of people between 35 and 50 show OA on X-ray. Okay. So what we now know is osteoarthritis probably starts about 15 to 20 years prior to when it actually shows up on X-ray. Okay. So it's a slow changing, progressive joint dysfunction. Okay, it's not something that rapidly wears out or anything like that. Cool. And there's again a graph of the percentage of osteoarthritis in the population. Now, going back to your question, sir, I showed that we do talk a little bit about hand osteoarthritis in here as well. Again, the stats show that 80% of 8-year-olds have OA in their hands. Yeah, it's so common. But GLA doesn't focus on hand osteoarthritis. No. Exactly. There's not a great risk, so one doesn't lead to the other, but there's a lot of factors. Genetics is one of them. So some people are more have a genetic predisposition to osteoarthritis. Lifestyle factors, weight, those sort of things. So OA itself is not a disease that spreads, but if you have those risk factors in one joint, you have risk factors in other joints as well. So the joints most frequently affected set of the joints of the hands, fingers, knees, and hip. And the number of people with OA increases with increasing age, but age does not cause OA. Okay. What does? It's a number of factors. So one is genetics, weight, overloading, lack of movement, diet, other inflammatory diseases. So there's a whole gamut of things that actually cause it. Trauma does. What that's sorry? How do you diagnose? It's a good question. Yeah, so it's a good question. So as I said, basically, if you're over 40 and you have pain that is related to movement, so when you move and you do something, it hurts. If that is also associated with stiffness, particularly in the morning, when you get out of bed and your knee feels stiff, your hip feels stiff, and if there's also any kind of crunching sounds, crepitus, or anything like that, then that is how we diagnose OA. Okay, so that's a far better way to diagnose it than getting X-ray. In the case of the hip, all those we may assess your hip and you may have a lack of movement compared to the other side, and that is just again it's an early sign of a joint dysfunction. It's like it's pre-osteoarthritis, if that makes sense. So you don't need if you've had no trauma to your hip, you don't need to go down the road of X-ray, MRI, those sort of things. Just a clinical examination is enough to diagnose a joint dysfunction. Does that answer the question? Yeah. So in the case of hips, you've got your hip is like a ball and socket like that, and then you've got the cartilage that lines the joint. And on top of that, you've got a structure called a labrum, which is like a little cushioning pad. And often the first sign we see is a little bit of a tear or a degeneration of that labrum. That doesn't show up in an X-ray. It shows up in an MRI, but it's just an early sign of OA in the hip. Okay. Exactly. Well, a hernia won't cause a restriction of the joint. So when I feel your hip, if your left side rotates really nicely, your right side doesn't, it's unlikely to be a hernia. Yeah, so it has to be pain associated with loading. So again, a hernia may may not be so much when you're walking or going up and down stairs, things like that, might be when you're like lifting. So it's that pain with loading, loss of movement, and plus or minus some, that old kind of creaking sounds in the hip and knee that we see. Yeah. Does that answer the question? Yeah. Yeah. So, again, for yourself, it really be a matter of having a look at the hip, but I'm not convinced rest would be the best port of call. All right, because as I said, cartilage needs movement and it needs loading to actually lubricate itself. Right, so this is a really, really important slide. This is basically a model of your knee joint. So as I said, the ends of the bone are covered by cartilage, and then the joint is then surrounded by what we call an articular capsule. And inside, and that capsule then produces synovial fluid. So your knee is basically full of fluid. And that synovial fluid is what actually lubricates and nourishes the cartilage. Okay. So that's a really important message. And then obviously you've got then the ligaments and muscles on side of the joint that help to stabilize the joint. And as I said to you, cartilage has no blood supply. So it gets its nourishment from that synovial fluid. Okay? And the only way that the knee produces synovial fluid is by moving and loading. So when you get told to rest for a few weeks, that's why you feel extremely stiff and that. And so through dynamic load, cycles of loading and unloading the joint, so basically cartilage is like a sponge. Think of it like a sponge. Pressure pushes fluid out, but when pressure is released, cartilage sucks fluid back in. That's what happens when you move. It's like a sponge where it's sucking that fluid back in. Okay? And so it's nourished through moving and taking weight through the joint as you're walking. So if you remember nothing else from today, just remember that motion is lotion. Okay, you need to move to lubricate your joints. Unfortunately, if you do too much movement or the wrong movement, then it can backfire. Okay, you get inflammation and overload. But that's what this GLAD program is about teaching you how to move effectively and safely. Yep. Well, again, any type of movement is okay. It just needs to be. So basically, we cover this more in the second session. But essentially, if you say you decide I'm going to walk up Cabaret Hill one day. Okay, so you walk up and down the hill and you do that. Now, if you think of pain from 0 to 10, where 0 is no pain at all, 10 is the worst pain you can imagine. What the research shows, if you're kind of exercising, when you're doing exercise, that pain stays below about 4 or 5 out of 10, and then it subsides within 24 hours, and that's actually a good amount of movement. Okay. Trial and error, and also, yep. 100%. Yeah. So basically, over time, the more you do it, your tissue tolerance starts to then go up. Okay. Again, you've got to say you do that. Exactly. Yeah. Yeah. So again, that's if you remember nothing else from today. Think about if you're walking up your set of stairs at home and it's 7 out of 10 pain by the time you get up there, then that's gone more into that overload. Okay. Yeah. Right. Same thing if you walk up some stairs and then there's an activity that would normally be provocative for your knee, and then you get pain the last 2 or 3 days, you've gone tipped it over. You know what I mean? And that's what this is all about, is giving you guys some guidelines. So that when you're in your day-to-day life, you can pace and space your activities so that you're putting the right amount of load, but not too much load. Yeah. And everyone will be different. Some people will be able to do very little. Some people will be able to do a lot. And that's not related to the amount of cartilage you've lost. It's related to a lot of factors. Okay. So does that make sense? Yeah. So again, that would be my take-home point from today is that, and it's very hard, when you've been in this kind of cycle of avoiding movements and not doing things, to then go back to doing these things. But I said if you follow these guidelines, and that's the beauty of the GLAD program, because you're doing these 12 sessions with a bunch of other people. There's also a physio there. You've got a sounding board to ask. To ask, I did this and it hurt. What did I do wrong? Yeah. So it's not just about the exercises. The GLAD exercises will help to strengthen your knee. They'll help to take your weight off. They'll help to make you fitter. That's part of it. But as big a part of GLAD is the actual education part of it. And obviously that's these sessions, but it's also the sessions with the physiotherapy program. Yeah. Bike riding. Yeah, again, that's great. So, bike riding is one of those really good things, you use when, you have your knees fit all that day, or, definitely movement will still lubricate it. Movement will definitely is better than sitting around, for sure. But you definitely do need an element of compression in the exercise as well. So you can't just bike ride. But it's a great, in the GLAD sessions where the warm-up is on a bike, that's definitely a great component of it. And it's a great way to start again if you've got a bit of fear about moving and walking and stairs. What's that? Yeah, great. Yeah, great. Yeah, no, great. But, right, again, so think of cartilage like a sponge. It's a shock absorber. When you move and compress, it draws that fluid into it, and the fluid is what nourishes it. Okay. If you don't move it, you don't load it, the sponge dries out. Okay. Right. So this is obviously a model of the healthy knee joint or healthy hip joint. So you've got cartilage on the ends of the bones, a meniscus, which is like a spacer or a shock absorber, articular capsule, synovial fluid, ligaments, and muscles. Okay. That's obviously the bottom picture is a healthy hip joint. So so you've got bone and then cartilage, and then I don't know if you guys can see it there, but the labrum is this soft tissue structure around the outside of the hip joint there. Okay. And that's often the thing in hips that starts to degenerate first. Okay. But, it doesn't show up in X-rays, but it's an early sign of joint dysfunction. All right. And that's more than likely, someone like yourself, that's probably more than likely what it is. Okay. Now the hip has no meniscus, so whereas the knee does. Alrighty, so as I said, what happens in a joint with osteoarthritis? So all joints, there's a balance of degeneration and regeneration. So, whenever you do exercise, cells and tissues need time to recover and repair. Okay, so it's like when you go to the gym or you do something, if you do too much of it, take a couple of days off, it helps to regenerate and repair. What happens with osteoarthritis is you get an imbalance of that regeneration and degeneration. And basically the disease progression may be due to cartilage being exposed to too much load all at once. So that's obviously an acute injury. Loads over a long time, overuse injury, and can happen with a normal load if the cartilage is diseased to start off with. Okay, so again, this is some of the stuff that we don't really know a lot about, but this is the classic genetic component, I think, where granddad had arthritis, your mum had arthritis, you've got arthritis. Some cartilage is more prone to the disease than other cartilage. Some cultures are more prone to it than other cultures. So yeah, basically it's can be a traumatic event. It can be from overuse. It can be from nothing at all. Okay, so don't think that your knee osteoarthritis is due to the fact that you slipped over 20 years ago. It could be any number of reasons. All right. Definitely. So if you say tear your anterior cruciate ligament, you're 100%, it's 100% chance you'll get osteoarthritis. Okay, because when your knee twists, the bones up together, and that butting together damages the cartilage. And as we know, cartilage can't repair itself, so slowly over time, it never recovers. So if you have a really acute knee injury when you're playing footy in your 20s where it's swelled up, then definitely that will be the cause of the osteoarthritis. But there's plenty of other people that have osteoarthritis that have had no traumatic event or, yeah. Okay. All right, osteoarthritis of the knee. So this is kind of moving into the symptoms. So, you may feel pain with weight bearing, stiff and unstable leg, knee giving out, knock knees or bow leg, crunching or clicking noises, and reduced range of motion. The muscle weakness around the joint can also aggravate this because you don't have that. When you get osteoarthritis of the knee, your knee swells, swelling causes the muscles to weaken and switch off, so you lose the muscular control around the knee, and therefore it feels more unstable, and again it goes into this cycle. So a lot of the GLA program is basically designed to strengthen up those muscles so you've got a more stable joint there. And just important for you to know, the clicking and grinding sounds are not dangerous. Okay, it doesn't mean that anything's getting damaged. It's just a sign of osteoarthritis. A lot of people have clicking and grinding joints that don't have osteoarthritis. Okay, so it doesn't mean when you go up and downstairs and hear your kneecap grind, it doesn't mean that the cartilage is getting torn away or anything. Yeah, again, follow those guidelines which we talk about, and your knee won't get damaged. And again, damage to the meniscus is part of the OA disease. So if you guys have ever had an MRI or whatever that's come back with a torn meniscus, again, it's an early sign of osteoarthritis. Okay, osteoarthritis of the hip. Again, pain with weight bearing, reduced range of motion. The pain is often outer part of the hip or deep inside the groin. Personally, I would say most likely findings we get deep in the groin there. The inner or outer part of the thigh, but it can also even go down to the above or inside the knee. But the most common part is in the front of the groin there. Okay, so again, if someone comes in that have no trauma, they've got pain in the groin there, that's osteoarthritis in its early stages. Okay. And again, again, you can feel pain in the knee because the same nerves that supply the hip also supply the knee. Okay. Absolutely. Yeah. Yeah. Now again, you've probably heard of a condition called trochanteric bursitis. That's again, if you have osteoarthritis of the hip, you'll have trochanteric bursitis. They kind of go hand in hand. One can be the more dominant player, but again, trochanteric bursitis is more a degeneration of the tendon that runs down the hip. But it's highly associated with osteoarthritis of the hip. Do those symptoms all seem pretty familiar to? Yep. Hand osteoarthritis. I'm actually not going to talk about that because it's not part of the GLA program. So again, it's very, very common. But I said it's not actually part of the GLA program, so I won't talk about that. All right, risk factors. So these are what we call modifiable risk factors. So modifiable risk factors are factors that we can actually change. Okay, and this is joint injury, joint overload, overweight or obesity, physical activity, and muscle weakness. Okay, so as I talked about, if you have a joint injury, you're really highly likely to get osteoarthritis. So the first way to prevent osteoarthritis is to avoid having severe injury to your knee or hip. Okay, now we're probably talking about more in the kind of sporting years, I guess, and but it's a very, very, very important way to prevent osteoarthritis. And sometimes it's hard to get the message across to young people because when you're young, you think you're invincible. But if you could prevent an injury in your 20s or 30s that would then stop you getting osteoarthritis, they're so easy to prevent. But I said when you're young, you feel you're invincible. The second one there is what we call joint overload from work and sport. So this is the classic too many working hours, too many sporting hours over years. You just damage your body, not giving it time to recover. If you're in a physical job or a physical sport or hobby, construction workers, soccer players, weightlifters, squash players. These are the type of people where it's just repetitive overload on those joints, not giving enough time to repair and regenerate. And that balance of regeneration, degeneration is offset. Again, part of the healthy exercise guidelines help prevent a lot of that. Obesity. This is a really, really big one. So for every extra kilogram load on the joint, you get about an increase 3 to 5 times more pressure in that joint. Okay, so again, first line of treatment for anyone with osteoarthritis is if you can lose 5% of your body weight, you are dramatically reducing the amount of load on that knee joint. Okay, and obviously exercise is part of that, but the diet is also a big part of it. So we highly recommend you see a dietitian, or there is online programs as well to help that aspect of it. We cover that a little bit in the GLA program, but obviously we don't do any of that. But it's as important as the exercise to help manage your weight. And then the next one there, physical activity. So I hope I've kind of really harped on about this at the start, that physical activity prevents dynamic load needed by cartilage to regenerate properly, and the neuromuscular exercises improves cartilage quality. And that's what GLA does. Inactivity worsens cartilage, muscle, and bone quality. Again, the people that have knee OA will always have weak quadriceps muscles. Okay, so it's just a straight line from one to the other. Weak muscles are worse shock absorbers. So when you don't have good quads, you don't have the ability for your knee to shock absorb. So you need more loading on it, and that's what the GLA does. It helps to strengthen your quads, strengthen your hips, so that when you're walking, it's got better stability, less load, and it's better at absorbing shock. Combine that with losing a bit of weight, and it dramatically changes the way the amount of load going through your knee or hip. And weak muscles equals poor movement and alignment, which means the joint tolerates stress less. So the classic one is if you walk upstairs, if your hip and knee muscles aren't stable, your knee collapses in like that. And what it does is instead of the knee moving nicely like a hinge like that, you get this unilateral stress, which focuses all the pressure on the knee joint there. Okay, so back to your question about walking up and downstairs, if we can train your muscles to stabilize that whole lower limb, so it's moving in a nice alignment, you're going to be getting a lot less load going up and down the stairs. All right? And these are the non-modifiable ones. So these are the things you can't change. So age, sex, and hereditary. Okay? We can't change genetics. We can't fight age. It depends on the joint area. So say in the hand, much more prone in females. In other parts of the body, it depends on the area. Yeah. All right, so how is osteoarthritis diagnosed? So hands up, who's had an x-ray of their hip or knee? So as I said, X-ray will show reduced joint space, osteophytes, which are like little bony growths on the joint, cyst formations, increased density of bone beneath the cartilage. Now, a lot of those are normal. If we X-rayed, a bunch of 50 or 60-year-olds, everyone's got those things. Whether you're in pain or not, whether you've got arthritis or not, they're normal. A lot of them are normal age-related changes. Okay, so really X-rays for hips and knees are, they're really quite a waste of time. All it does, as I said, is sometimes increase the fear associated with your osteoarthritis. Same thing with lower backs as well. There is absolutely no reason to prescribe an X-ray for your lower back. It doesn't, from a clinician's point of view, it doesn't tell us anything. There's no correlation between what you see on X-ray and what you see in the clinic or how bad the symptoms are. But most people still get referred for X-rays. So hopefully over time that will change. But yeah, still a lot of people want to get an X-ray because they have the belief that it'll help the clinician or the surgeon or the doctor manage it, and there's just no indication for that at all. Okay. No, ultrasounds are different. Yeah, so ultrasound is a different thing. Yeah, so ultrasound is more looking at soft tissue structures. But yeah, no. But I'm just talking about purely X-rays of the hip and yeah. Yeah, you're exactly right there. So what I should say is X-rays, what they are good for is ruling out nasty stuff. Okay, so nasty or unusual stuff. Okay, so tumours, exactly. Other things like osteoporosis, Paget's disease, all these sort of things that are a bit unusual. But there's usually other things associated with that. I mean, so I'm not saying X-rays are bad, but in your 40-year-old, 45-year-old patient that has a stiff hip, it's not necessary. Yeah. What they're often used to rule things out rather than rule things in. Okay, so yeah, that's a good question. Yeah. And obviously, as you get older, if you're medically not so well, if you're showing other signs, then the GP will definitely want to do an X-ray to rule out other things associated with that. And again, as I said, it's common to experience symptoms of OA for up to 15 years before it shows anything up on X-ray. Okay? And the link between X-ray changes and symptoms is generally very, very poor. And number one thing is the patient's your symptoms rather than the X-ray that guide how we treat and how we exercise you. Okay? So someone with bone-on-bone arthritis with very little symptoms, very little swelling, we would tend to push you a little bit more rather than someone that's got mild OA but a lot of swelling, a lot of pain. So it really is based on what we find in the clinic. Symptoms of osteoarthritis. Symptoms develop slowly. There's that feeling of instability, looseness or giving way, stiffness, reduced range of motion, pain on weight bearing, pain at rest, and then a red, hot, or swollen joint. And again, this all varies from person to person. One of the big findings is stiffness, especially in the morning after sitting down for a period. Okay, that's a real telltale osteoarthritis sign. Whereas something more systemic or nasty, you get more pain at rest, pain at night, those sort of things. But that classic, when you rest or you lie down, you've got to get back up again, it hurts. That's classic osteoarthritis. In the beginning, pain only occurs during weight bearing, but later the pain may also occur at rest and at night, and that's because of the inflammation. So you overload the joint during the day, it gets inflamed, you feel that inflammation at night. And the swelling and redness is, again, that's a symptom of inflammation. Okay, so any condition with an itis on the end, itis means inflammation. So osteoarthritis is an inflammation of the joint and cartilage. Right, so common problems with hip and knee arthritis. This is kind of what you feel functionally. Is you're typically pulling on socks and shoes, standing up from a chair, standing or walking for a long time, vacuuming, cleaning the floor, leisure activities and sports. This is the stuff that you're not able to do because of osteoarthritis. And again, I'm sure you guys can recognise these are the activities that stopping you doing. Yeah, so I'm sure you feel that in your day-to-day life. Yeah, so rheumatoid arthritis is a completely different beast. So osteoarthritis tends to be more in load-bearing joints, whereas rheumatoid arthritis tends to affect more the hand and other sort of joints. Yeah. So again, Vlad doesn't deal with that at all. That's a completely different thing. Well, again, osteoarthritis tends to affect that one joint, whereas rheumatoid arthritis is more systemic. So if you've got all those swelling and changes in those joints, then yeah, certainly you'd be looking at getting investigated for rheumatoid arthritis. Yeah. And rheumatoid arthritis is much more common in females. Yeah, it's a completely different sort of kettle of fish. I won't talk about the hand osteoarthritis. Fatigue. So again, fatigue is a big common with osteoarthritis. People may stop doing physical activities. They like you feeling tired and lacking energy. And once you do the things that you need to do during the day, the vacuuming and the cleaning and the whatever else, you've got no time to do anything else or no energy to do anything else. Fatigue cannot be slept away, and it's different to ordinary tiredness. So fatigue is very, very common in inflammatory joint diseases, and that's what osteoarthritis is. So it's different to tiredness. This is fatigue is a different beast. We do not yet know the reasons for fatigue, but it might be a combination of the ongoing disease process and long-standing pain and stiffness. So we know that chronic diseases cause changes, cortisol release, these sort of stuff, and that causes fatigue. The reasons we're not 100% sure of yet, but it's a normal symptom of inflammatory joint diseases. Yeah, that's exactly right. Yeah. Yeah. And show of hands, who does feel that arthritis does cause fatigue or kind of wears down? Yeah. Yeah. Yeah, great. Yeah. Yeah. Absolutely. Yeah. Right. Yep. Yep. That's hard to think, isn't it? Hydrotherapy is a great part of the package. As I said, it's physical exercise, and it does strengthen. What it doesn't do is it doesn't load the joint. Okay, so that's where you also need to supplement it with weight-bearing exercise, walking, something like that. Yeah. Yeah. Hydrotherapy is great, absolutely. So this is basically the osteoarthritis treatment pyramid. Sorry. So everyone should be getting exercise, education, and weight control. Only some people should be getting pharmacological pain relief, aids and passive treatment, and very few people should be getting surgery.
Well, I had just, I was supposed to totally replace the every day, but something happened with my back, so I just thank you. A lot of them.
Yeah, so there's many people referred to surgery that have never been prescribed an exercise program. And any surgery has an element of risk, has an element of complication. It's got a fantastic, surgery's great, it's got a fantastic place, but only once exercise, weight loss, education has not worked or reached its limit. Okay. So I said everyone seeking care for joint pain should be offered education, exercise, and weight reduction. If the first line treatment doesn't provide enough relief, it should be complemented with pain relief, meds, TENS, manual therapy, etc., etc. And for those with very severe symptoms, and this is really only 10 to 15% of people with osteoarthritis, then joint replacement is a fantastic option. Okay. But it's the end of the line. Yeah. Yeah. And as I'll explain, with GLAD as well, one of the important things that was shown is that people that do the GLAD program are much less likely to go on to having total knee or total hip replacement, but also people that did GLAD and then had a total knee or total hip replacement had a far better outcome. So if nothing else, if you have severe osteoarthritis and you do this program and get a hip replacement or knee replacement, you'll have a better outcome than if you don't. The reason that is you've built up some strength. So when you go to do these exercises afterwards and you've got to move afterwards, the tools are still there. Okay? Whereas if you have been very inactive, very sedentary, it's much harder to recover from. Okay? Right, so exercise is effective for pain relief. Different types of exercises like walking and strength training are effective in relieving pain. And neuromuscular exercise, which is an important component of GLAD, is just as effective for pain relief. In addition, targets the OA joint and improves stability and trust in the affected joint. So the GLAD exercises are designed to improve the neuromuscular control around the joint. Okay. The dose of exercise is very, very important. More exercise is better, but as I said, it's about exercising in those parameters. During the neuromuscular exercises, you'll practice doing things like you do every day, like getting up and down the floor, rising from a chair, walking, etc., with good movement quality. So like we said, we teach you how to walk up and down stairs with good quality. We teach you how to get up and down off a chair with good quality, so that you're putting the minimum amount of load through the knee. Okay. We get your core stronger so that, if you're strong through here, you have better control below that. So there's a lot of components to it. Weight reduction. So being overweight increases the risk of the cartilage and joint becoming overloaded, and a relatively small reduction in weight has a big effect on joint load. So for every kilogram you lose, the weight on that joint is reduced by at least 2 to 3 times. It's not a 1-to-1 ratio, it's a 1-to-3 ratio. Okay. So but conversely, if you put on a kilogram, you get 3 times as much. So it can work in your favour or against your favour. But weight loss is extremely important. And I hope that I've explained that, why we need to exercise. Okay. So cartilage is like a sponge. It needs movement, compression to lubricate itself. Right, so we're going to talk about some of the additional treatments now. So these are the second-line, second-tier treatments. So medication, non-steroidals, cortisone injection, non-steroidal anti-inflammatories, Voltaren, Nurofen, Brufen, that sort of stuff. They do provide some short-term relief, but that relief is not sustained. Okay, so it's only a short-term benefit. It only lasts really for the time that you're taking it. Whereas exercise, the GLAD program, the people that stopped after 3 months still have the benefits 12 months later. Okay, so it's a sustained effect. And that's due to the fact that your muscles have become stronger, you've lost weight, and all those factors we've talked about. Cortisone injections. Has anybody had a cortisone injection for the hip or knee? Okay. For your right knee? Okay. So again, it's temporary relief. Okay. Yeah. 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 The other cortisone does also cause the cartilage to wear down quicker. So one's okay, but if you get people that have repeated cortisone injections, it will actually wear out the cartilage quicker. Yeah. So, but again, we see people, common thing, we get people who've had 2 or 3 cortisone injections and ask them, have you ever tried an exercise program? Have you ever been referred to a dietitian? No. So, has anyone taken glucosamine? Yeah. Well, the answer is there's actually no evidence that that it works. Yeah. Yeah. So, yeah. There's no harm to it. There's no harm to it, but there's no evidence that it actually. There is some people, that certainly will have good effects from it, but is it something we can recommend? No. Yeah. Again. Yeah. Fish oil's a good tablet. That's part of it. The evidence is that there's very low quality trials, but yeah, I think the part of the problem with osteoarthritis is all these treatments that are kind of it's like anything in life, it's like you take this pill, it'll make it better. That's okay to do that, but if you haven't done an exercise program and a weight loss program, then nothing else is they're all second-line treatments. They're okay adjuncts, sure, take glucosamine, take fish oil, whatever. But if you're not doing strengthening exercises, you're not doing functional exercises, then that's not a way to manage your arthritis. Yeah. Yeah. Again, there's no. Yeah. Again, that's an unknown. But as it stands, there's no evidence that glucosamine works. And you could take, I don't know how much glucosamine costs, but you can take $400 worth of glucosamine over a few years, and you can spend that on that. Or you can spend $400 on, to talk about a GLAD program, something like that. It's chalk and cheese in terms of what evidence tells us. So, yeah, all that stuff it doesn't harm, but there's no evidence that it works. There's no evidence that if you took a jelly bean or a glucosamine pill every morning, there'd be any difference to the placebo effect. Yeah, exactly. Yeah. Yeah, well, there's, exactly, yeah. It's big fun, the sort of vitamins and it's big business, you know what I mean? But unfortunately, a lot of it is just placebo. So, other sort of second-line treatments, we've got foot orthoses, TENS, acupuncture, taping, all these sort of things, you know, they can help a little bit, definitely. But again, just go back to that treatment pyramid. They're second in line treatment options. You know, using a walking stick in the other hand does reduce load on the joint. Absolutely fine to use. You know, braces, you can get, you know, knee osteoarthritis deloading braces. Again, they're great. They work a little bit, but they shouldn't be instead of exercise, education, and weight loss. Okay. Yeah, I mean, that's most of the braces out there are not that supportive that would be the case. So, you know, there's certain, I guess, there's that argument, but there's nothing wrong with the brace. But you know, you've got to strengthen those muscles and go do that as well. Yeah. Yeah, laser can't stimulate your cartilage to produce fluid, which lubricates the joint. Okay, it's again, it's a placebo effect. Yeah. It's a good pain relieving tool, as is TENS, but in terms of helping osteoarthritis, yeah, no. Yeah. All right, has anyone had arthroscopic surgery of their hip or knee? Yep. Yep. So again, the research shows if you went into that surgery and they just cut your skin open, stitch it back up again, yeah, there's actually no evidence that, so, you know, the current GP guidelines, there's no place for arthroscopic surgery for hips or knees. Yeah, that's, did you need, yep, again, if your knee's locking, that's a different thing. So if you've got a bit of cartilage that's torn and it's causing your knee to lock, that's a different thing, but but if you have a small tear in your cartilage, if you compare the people who had surgery or don't have surgery, 12 months are exactly the same. Yeah, again, there's two different things. There's a locked knee and there's a knee that's not locking. So if you're in private health fund now, they won't actually pay for you to have an arthroscopy of your knee unless your knee is locking. So that's a very specific kind of condition. But you know, someone who's got a bit of knee pain shows on MRI they've got a bit of a cartilage tear. There's no reason to have an arthroscopy there. But if you have got a torn bit of meniscus or cartilage that's causing your knee to lock, so it means, you know, it gets stuck and you can't move it. That's a different story. That doesn't right now. Debridement where they basically, you know, they clean out some of that bony growth, or you know, those little bits of kind of growth on the bone there. So the idea is to try and smooth out the cartilage a little bit, sort of thing. Yeah. Again, there's no difference to placebo in those things. Again, we see very few of them these days. The only reason for arthroscopic surgery is really if you've got a torn meniscus, so there's actual, you know, significant cartilage tear there. Keyhole surgery. Yeah. Yeah. So this is different to a joint replacement. Yeah. Cool. Total joint replacement. Has anyone here had total joint replacement? Yep. Of your, yep. Yep. Do you have good results? Yep. Great. Yep. Good. You know, again, it's a fantastic procedure. And you know, it's a great thing when those first line treatments haven't worked, but it's a big surgery. You know, it's a big surgery. So we want to make sure that we try everything else and, you know, be in the best possible position to get a good outcome after that surgery. And so these are basically the, you know, results of those first line treatments. So as I said, you know, when you compare exercise therapy to non-steroidal anti-inflammatory drugs or paracetamol, you know, exercise is really the key thing here. And the results after GLA participation, so people reported less pain, better function, high quality of life, and fewer people taking painkillers. Now, they've had over 13,000 people do this program in Europe. And as I said, there has been an average of 32% reduction in people's symptoms. There was a 70% reduction in people going on to having total hip replacement. So they're pretty big numbers. There was a significant reduction in the amount of painkillers people were taking. And so 30,000 people is a lot of people. It's a big study, so this is pretty well proven now. And then so the next session, we go over how to safely exercise, what sort of exercise you should do. I talked about it a little bit before, you know, what are those kind of parameters we should use to exercise, and how to self-manage your arthritis. So some of the difficulties, some of the activities of daily living, and coping strategies. I'm just going to go just over the benefits of GLAD again. So again, talking about, you know, when you start GLAD, when you finish GLAD at 3 months, those improvements were shown to last 12 months afterwards. Okay, so and I said 72% of people delayed or avoided having hip or knee replacement. So what is the GLAD program? So basically, this is a flowchart basically of what happens. So you come in and have your assessment with the physio, okay? And what we do in that first session is we get baseline measures in terms of how you do a couple of tests to find out exactly how capable you are. One of those is what we call a sit to stand test, and the other one is a timed walk test. So basically, getting a show us how many times you can sit to stand, and how many times you can walk in a certain time frame. And then we retest those things after you've done the GLAD program, and that's what we use as our objective measures. After that first assessment, if you're eligible for the GLAD program, then as I said, we conduct those baseline measures, and you then have the option of going onto the GLAD database. Okay, so it's actually an international database which you log into, you put all your details in, and it's purely just designed from a research point of view. Okay, so we want to know, is this an effective treatment, and we want to be able to prove to health funds, Medicare, all this sort of thing that this is an effective treatment. Okay, so but that's completely optional. You don't have to do that. It's just from a research point of view. And then with GLAD, you do 2 education sessions. This is the first one. And then you also do a second education session where we go about talking about those sort of things that we talked about before. And then you have the choice of either signing up for the supervised exercise sessions or doing the exercise at home yourself. Again, the evidence is quite clear. If you do the exercises under supervision, you have a much better outcome. And the reason for that is myself and Lauren are there going, watch that knee, you know, let's just correct that hip there. Whereas when you do it at home, you don't really know what you're doing in terms of alignment. So it's certainly an option for you guys to do it at home. But there's 2 issues. One is you don't have a physio watching over you like a hawk to sort of, you know, check you're doing it correctly. Compliance is obviously an issue. It's much more motivating to do it in a group, but it certainly is an option. Okay. And to be part of the GLAD program, you've got to do a minimum of 12 sessions, and that's done over a minimum of 6 weeks. So the ideal scenario is you do 2 sessions a week over 6 weeks. Yeah, so it's completely covered under private health insurance. Yeah, because it's taken by physio. And so what private health funds want is they want to be taken by physio. They want there to be a before and after measure. And you've got to be in a program with small amount of people. And we also take notes on it. So you don't need a doctor's referral. The only reason you get a doctor's referral is the first and last sessions, the one-on-one sessions with the physio. They can potentially be claimed under Medicare, okay? But it's not necessary. So you can't claim the group sessions under Medicare, but the initial and the follow-up, the one-on-one sessions, you can. Does that make sense? Yeah. But all of the group sessions are covered under private health. Yeah. Because it's classed as clinical exercise. So. Sorry? But you don't need a doctor's referral. No. Are you talking about? So you don't need a doctor's referral. So anyone can join the GLAD program. So you don't need a doctor's referral. However, has any of you been treated under Medicare on the EPC plan? Yeah. So you can use those sessions. Yes. Yeah. Yeah. So you can use 2 of those sessions for your first and last appointment with the physio. Yeah. Does that make sense? But it's not necessary. Yeah. And you can just come in and do these sessions under a physio. Absolutely. Yeah. You don't need a doctor's referral. From. Yeah. It's pretty. I mean, you're probably going to get about 50% back. So we'll talk about. We've bundled this all together. So what we call out, so you got the number of options. One is that this is by far the most cost-effective option. So what I call our GLAD pack is where you get 2 one-on-one sessions with the physio, you get 2 education sessions, you get 12 supervised GLAD exercise sessions, and that would normally cost $560. GLAD pack is $440. Okay, so that's the whole GLAD program. Okay, and for anyone that signs up today, we'll also take a further 10% off, so it's $396. That's only today. You don't, sorry. Yep. Yep. Not at all. Not at all. So basically, anyone can participate in GLAD. Doesn't matter how unfit you are. Doesn't matter how overweight you are. Doesn't matter how bad your osteoarthritis is. Anyone. The exercises. There's all different levels of exercises. So we grade the exercises to the individual. That's the idea. It's a small group, and what you do might be different to what another person does. There's all different levels of exercise. Yeah. Okay. That's for the whole pack. Okay. But if you just want to do the exercise sessions, you can buy them individually. There's no problem at all. So some people may just choose to do one session and then come back and do another one in 2 weeks or something. You know what I mean? That's absolutely fine as well. Yeah.